Welcome back, dear students. Next, we are going to see thyroid swellings. The benign thyroid swellings we are going to discuss regarding the benign type of swellings like Graves' disease, goiter, all those things we are going to discuss now. Okay. So now, before going to benign swellings, let us discuss what are all the swellings in thyroid. What are all the swellings in thyroid? So the swellings in thyroid are the following. We can divide it under four headings. We can divide as diffuse swelling, diffuse goiter, or we can divide it as nodular goiters, and we can say it as inflammatory swelling of thyroid, or we can discuss it as neoplastic swelling of thyroid. So these are the broad heading of thyroid swellings. So broad heading of thyroid swelling is diffuse goiter, nodular goiter, inflammatory, and neoplastic. Diffuse goiter is one which is having physiological thyroid swelling. Physiological goiter is diffuse, the gland will be enlarged, diffuse. Then we have Graves' disease. It is also a diffuse swelling. Even colloid goiter will be diffuse. Colloid goiter can be diffuse, or in future can even become a nodular also. Colloid goiter can become nodular also. So it can be a solitary nodular goiter or a multinodular goiter. It can be solitary nodular goiter or multinodular goiter. So inflammatory, you know very well the various types of thyroiditis like Hashimoto's, Riedl's, De Quervain's. Hashimoto's, Riedl's, De Quervain's are the various type of thyroiditis we have. And neoplastic, we have all the malignancies like papillary cancer, follicular cancer, medullary cancer, anaplastic cancer. So especially final year students, you can get an essay question on the various swellings on thyroid. So discuss about the various etiology, FNAC findings and investigations of thyroid swelling. You can get an exam. So this is one of the broad outline of what are the thyroid swellings we have. Okay, these are the broad outline of thyroid swellings. Okay, so when we start discussion on thyroid, we should know certain clinical features of thyroid swellings. So clinical features include, it can be present as hypothyroidism. So the swellings can present as hypothyroidism, or they can present as hyperthyroid swellings. Hyperthyroidism and hypothyroidism are the two types of physiological features. So let us see what are all the clinical features in a patient with hypothyroidism. What are the features? So when you see the hypothyroid patients will look obese. This hyperthyroid guys will look slim. But the interesting point is, though hypothyroid patients look obese, the amount of food they consume will be very less intake, but increased weight. Whereas hyperthyroidism, these are the guys, sometimes you can see some of your friends, they will be eating a lot of food, they will take full biryani, 7 to 8 idli, parota, everything, but when in spite of eating that much, they will be very slim. It is due to the basal metabolic rate in the body is high. Increased basal metabolic rate makes them slim in spite of increased intake. In spite of increased intake, they will look slim. In spite of increased intake. So hypo and hyper, I'm telling you the features, clinical features. But hypothyroid patients cannot tolerate cold. Cold intolerance is seen. Hyperthyroid patients will have heat intolerance. So heat intolerance. Hypothyroid patients are having constipation. Hyperthyroid patients will have diarrhea, increased bowel movements. And when you see hypothyroid females will have menorrhagia. They will have increased bleeding. And these guys, hyperthyroid, will have oligomenorrhea. But the interesting point is, these girls with hypothyroidism, they will go for severe menorrhagia, and finally they will go for amenorrhea because of anemia. They will finally end up in amenorrhea. When you test the reflexes in the tendon reflexes, in hypothyroidism is very less. It is very less. In fact, they have a reflex known as pseudomyotonic reflex or hung up ankle reflex. Ankle reflex is hung up. Once you tap the ankle, it will become hung up. It won't be having a full action. When you tap it, it will hang up. So hung up reflex or delayed ankle jerk. It is also known as delayed ankle jerk. So like that, the tendon reflexes are very poor in hypothyroidism. Whereas in hyperthyroidism, there is increased tendon reflex. And there is increased fine tremors. The hand will have fine tremors. The tremors in thyroid will be like this, fine tremors. They will have fine tremors. Increased tendon reflex. Okay, they will have increased tendon reflex, fine tremors will be present. Okay, they will have fine tremors and increased tendon reflex. And also they have eye signs, which I am going to discuss separately. They will have eye signs. They will have classical eye signs, which is one of the important, the main eye sign is exophthalmos. So exophthalmos, eye sign, please don't forget, they will have exophthalmos. I will tell you all those eye signs. Okay, apart from that, what are the other interesting features means they will have loss of eyebrow. The eyebrow will be lost. They will have hypothyroidism, will have loss of eyebrow. They will have macroglossia, very big size tongue. Macroglossia will be there. They have mask-like faces. These guys are depressed guys. They have severe depression. So all these are other features of hypothyroidism. Loss of eyebrow, macroglossia, mask-like faces, depression. All these things are seen in hypothyroidism. What are the other features in hypothyroidism means they have classically some interesting features known as pretibial myxedema. What do you mean by pretibial myxedema? It is a deposition of mucopolysaccharides. Please remember, it is a deposition of mucopolysaccharides in front of tibia. In front of tibia, there is mucopolysaccharide deposition. So this is a misnomer. Though myxedema means hypothyroidism, it is named wrongly for hyperthyroidism. So it is a misnomer. So other interesting features: pretibial myxedema and acrobachi. Acrobachi is subperiosteal resorption of fingers. Subperiosteal resorption of fingers looking like clubbing. Fingers in hand as well as in legs will be acrobachi. It is one of the late features of hyperthyroidism. It's a very late feature. So pretibial myxedema, acrobachi are all late features. These are all late features. So these are the interesting points in hypo and hyperthyroidism. So in hypothyroidism, what are the diseases? Named diseases means we have cretinism and we have myxedema. So cretinism is a hypothyroidism in pediatric age group. Myxedema is hypothyroidism in adult age group. Okay, pediatric is cretinism, adult is known as myxedema. Hyperthyroidism, there are many causes. I will tell you some important causes now. Graves' disease and Plummer's disease are two causes of hyperthyroidism, interesting causes. So in Graves' disease, there is primary toxicosis. So please remember, in Graves' disease, there is primary toxicosis. In Plummer's disease, there is secondary toxicosis. What does it mean? So it is a typical final year topic. Graves' disease is nothing but a diffuse enlargement of thyroid gland like this. It is an autoimmune disease, diffuse enlargement of thyroid gland, along with the toxic features simultaneously happening. Whereas in Plummer's disease, there is a nodule for a long period of time, and now suddenly going for toxic feature. Long-standing nodule, now going for toxic feature is known as secondary toxicosis. So long-standing nodular goiter going for toxic feature now is known as Plummer's disease, and it is usually a solitary nodular thyroid. A solitary nodular thyroid going for toxic features is known as Plummer's disease. So primary toxicosis will mainly affect the CNS and eye signs will be present. They will mainly affect CNS and eye signs will be present. In secondary toxicosis, mainly affect CVS. It will mainly affect CVS. Why? Because these guys are already old guys. So these are already old guys. So they will have more of CVS manifestation because already their heart is weak. So what are the most common manifest means? Sinus atrial tachycardia is the most common manifest. So please remember, the most common CVS manifestation is sinus atrial tachycardia. Others are atrial extrasystoles, atrial fibrillation, congestive cardiac failure, thyroid storm, then Lerman's scratch sound is heard in the left side second intercostal space. Some of these guys with hyperdynamic circulation will have Lerman's scratch sound in the second intercostal space. It is due to rubbing of pleura and pericardium. Due to rubbing of pleura and pericardium, you can hear Lerman's scratch sound. So please remember, the most common feature is sinus atrial tachycardia is the most common CVS feature of these guys. Okay, so please don't forget the basic of hypothyroidism and hyperthyroidism. Basic difference between hypothyroidism and hyperthyroidism. I will stop discussing hypothyroidism with this point because hypothyroidism is not a surgeon's case, it is a medicine case. So but I will tell you, in a hypothyroidism, due to whatever may be the cause, the first treatment will be giving 50 to 100 microgram of tablet thyroxine will be given for these guys. So we should give them 50 to 100 microgram of tablet thyroxine. And I already told you the most common cause is iodine deficiency in India. Iodine deficiency in India. Most common cause in Western countries is Hashimoto's. Okay, so in India it is mostly due to iodine deficiency goiter. India. Okay, Western countries it is due to Hashimoto's. So now there is an increasing trend of Hashimoto's even in India. So if it is due to iodine deficiency, we have to give them iodine supplementation. We have to give them iodine supplementation along with tablet thyroxine. If it is an Hashimoto's, sometimes these patients will need painkiller tablets also when they have severe pain in thyroiditis. So anyhow, hypothyroidism is treated with dose of 50 to 100 microgram of tablet thyroxine, and this dose is what we call it as supplement dose. Supplement dose. This dose is known as supplement dose. So hypothyroidism, the dose given is known as supplement dose. 0.5 to 1 milligram tablet is available in the market. 0.5 to 1 milligram tablet we give it is known as supplement dose of thyroid. Okay, please don't forget hypothyroidism. That's all. There is nothing much for me to discuss in hypothyroidism. So I'm directly going into the Graves' disease. Graves' disease is a high yield topic for your exams. So Graves' disease is a high yield topic for your exams. I'm going to discuss in depth of this Graves' disease. Okay, I'm going to discuss in depth of this Graves' disease now. So Graves' disease is most common cause of hyperthyroidism. Please remember, it is the most common cause of hyperthyroidism. Hyperthyroidism. This is the most common cause. It is an autoimmune disease with a strong familial tendency. It is having association with HLA-B8, HLA-B8, HLA-DR3, HLA-B8, HLA-DR3, HLA-DQ1. These are the associations seen in Graves' disease. And Graves' disease will have a diffuse enlargement of swelling. Diffuse enlargement of thyroid gland will be present, and it will be soft in consistency, and it will be highly vascular. It will be highly vascular. You can hear the thyroid. You can feel the thyroid trill at the superior pole when you touch the thyroid gland. You can feel the thyroid trill at the superior pole. You can feel the thyroid trill. When you palpate and find it, it is trill. When you auscultate with the stethoscope, it is known as thyroid bruit. So auscultatory finding is bruit, and palpatory finding is trill. So this is all you can find out in thyroid. So trill is palpated, and with the stethoscope we can hear the bruit sound. Okay, and we can also hear the loud venous hum is also present. All these are due to increased sympathetic activity causing hyperdynamic circulation. Okay, so now at this point of time I would like to tell you some tests, clinical tests in thyroid. Clinical tests in thyroid. Certain test, named test I want you to remember from thyroid. However, I am discussing all this as video in clinical examination videos separately. Let me tell you the important test you should not forget during your exam, because near exams you will not have time to see all those videos. But when you are doing your first time preparation, you have sufficient time to see the videos. But when it is the near exam, you can only read the document and go. So I am just telling you the various tests available in thyroid to do in clinical examination. Thyroid is always examined from anterior or posterior. Always examined from behind. Please remember, it is examined from behind. First point. If the patient is having a short neck like this, there is no neck at all, you cannot even palpate the thyroid gland. Such patients, you ask them to do one test like this, clasp the hand like this, and hyperextend the neck. So for short neck individuals, the test done is known as Pisillow's test or Pisillow's method. Pisillow's method is used for short-necked individuals. So just remember the catch point in each. Pisillow's method is used for short-necked individuals. You ask them to keep the clasp it like this and extend. Pisillow's method. And if a patient is having a retrosternal extension, you are not seeing the lower border of the thyroid gland, and it is having a retrosternal extension, you want to look for compression of the superior vena cava. Such time you should do one test known as Pemberton sign. Pemberton sign is for retrosternal goiters, to look for compression. You ask the patient to raise both arms and touch with the both arms the ear. So when they are doing like this, the congestion will be seen in the face in a retrosternal goiter. Pemberton sign for retrosternal goiter. So then there are some specific tests you come anteriorly. Otherwise you examine from posteriorly. Some tests you come anteriorly. The tests are Lahey's test. NEET. The AIMS 2019 November question. Lahey's test. You push the thyroid swelling from one side to other side and examine with all other 4 fingers. Push it from one side to other side and examine with 4 fingers. This is 4-finger examination. 4-finger examination method. Lahey's test. And the next test is Kreil's test. Kreil's test is done for doubtful nodules. You have a doubtful nodule, you ask the patient to extend the neck, examine with only thumb like this, and ask them to swallow. If there is a small nodule, you can palpate with the thumb. So for doubtful nodules, using only thumb is known as Kreil's test. Because I'm telling you here, I'm not putting the videos here, because this is one video which you will revise during your exams, and I want you to just know what is what. At this time I cannot explain you the videos here. I will put a separate session is added in this app. We'll be having clinical examination videos with a live patient and myself examining those patients. I will explain it everything there. Here you know the names: Pisillow's method, Pemberton sign, Lahey's test, Kreil's test. Pisillow's method, Pemberton sign, Lahey's test, Kreil's test are the tests available in thyroid examination. In thyroid examination, the various tests available are this. Okay, what do you mean by trial sign? Trial sign. What do you mean by trial sign? In case there is a thyroid swelling here, if it is pushing the trachea, you can see this left side sternocleidomastoid prominent. So if there is a thyroid swelling pushing the trachea, the opposite side prominent sternocleidomastoid. Prominent sternocleidomastoid muscle is known as trial sign. So this is known as trial sign. So these are the tests done in thyroid swelling. All this you should do. All this you should do. And what is Berry sign? Berry sign. Okay, Berry sign is a testing of carotid artery against the vertebra. You have to palpate for carotid artery against the vertebra by compressing. You should examine only one side one time. You should examine for palpation of carotid artery. Okay, if carotid artery pulse is not felt, it is known as Berry sign. Berry sign is carotid artery pulse is not felt against the vertebral transverse process. Why is it not felt? It is because of the engulfment of the tumor. Engulfment of the tumor, you will not feel the pulse. So it is not felt, it is Berry sign. So Berry sign, please don't forget. So all these are clinical tests in thyroid. I want you to remember: Berry sign, trial sign, Lagis test, Trials test, Pemberton sign, Piscilos method. Okay. So then you have to know for toxicosis, what are the special tests? For toxicosis, the things you should do are you should examine CNS, you should examine CVS, you should examine eye signs. To look for toxicosis, these are the things to be tested. CNS is tested by looking for increased reflexes, exaggerated reflexes. You can see the exaggerated reflexes, and you have to look for tremors. So the tremors, I already told you, it is fine tremors. You have to ask the patient to extend the fingers like this and keep a piece of paper on the hand like this. Keep a paper of hand. They will have fine tremors. Okay, and to look for fasciculations in the tongue. We have to look for fasciculations in tongue. To see for fasciculations in tongue, clinical case DAS gives a wrong answer. We should not protrude the tongue out. If you protrude the tongue out like this, even a normal patient will have fasciculations. Therefore, to look for fasciculation, open the mouth and examine the tongue inside. You have to examine the tongue inside the mouth by opening the mouth. Don't ask them to protrude the tongue out. So these are the things you should look in CNS. In CVS, the most important thing is sleeping pulse rate. That is the ideal thing you should do. We have to do a sleeping pulse rate testing, and there is a grading of sleeping pulse rate known as Kriles grading. So there is a sleeping pulse rate grading known as Kriles grading about the pulse rate. So I will go midnight along with the staff nurse and examine the pulse rate of the patient. This is what you should tell in the exam. How will you do sleeping pulse rate? I will give tablet phenobarbital as a night dose. I should not give diazepam, it will increase the pulse rate. I will not give alprazolam. I will give tablet phenobarbital as night dose, and I will go and examine the pulse rate in the midnight. And I will calculate the Kriles grading of pulse rate is available. Please remember this. Okay, so pulse rate, sleeping pulse rate is the best one to say there is a serious injury to the thyrotoxic patient. And eye signs, there are so many eye signs. Eye signs I'm going to discuss now all about exophthalmos. I am expecting this year you will be getting to demonstrate one eye sign in AIMS. Okay, I am expecting this year you may get an eye sign in AIMS. So eye signs in AIMS. So eye signs, what are all the eye signs? What are all eye signs? So one Graffy's sign. I used to read like one Graffy's lid lax sign. I'm demonstrating all these videos in a clinical video session. Just see one Graffy's lid lax sign. So one Graffy's lid lax sign. As I am examining the patient, I will ask the patient to see my finger continuously like this. Go down, go up, go down, go up. As I am doing like this, the patient's eyelids will lag down. So this is non-Graffy's lid lax sign. Dahl-Rimte sign. Dahl-Rimte sign. Dahl-Rimte sign is visible upper sclera. Visible upper sclera. You can see in my eyes, you can see the lower sclera many times, but upper sclera is visible only if you have a exophthalmos, upper scleral border. Visible upper sclera is known as Dahl-Rimte sign. Then Stellwachs sign. Stellwachs staring look like that. You will be patient will be staring you like this. You will be simply seeing you, but he looks as if he is staring you. Stellwachs staring look sign. Staring look sign. Dahl-Rimte is visible upper sclera. Stellwachs staring look. We can also say Stellwachs visible upper sclera as lid retraction sign. Lid retraction sign. So then comes very important sign known as Geoffroy's sign. Geoffroy's sign. In Geoffroy's sign, you ask the patient, keep the patient head fixed, ask him to see the ceiling. If I'm going to see the ceiling, what I will do? I will do wrinkling like this and see like this. But if you ask these guys to see up, they will have already eyeballs are outside, so they will just like that see without wrinkle. So that is what said as absent wrinkling sign, absent wrinkle sign. Then comes the Mobius sign. Mobius sign. You ask the patient to converge the eyeball to the fingers like this. You do like this and ask them to converge the eyeball. They are unable to converge. Inability to converge. So you'll be reading those things in ophthalmology also, but I'm just giving you all eye signs. Inability to converge the eyeball is due to paralysis of intraocular muscles. So therefore, you can see the first three as mild exophthalmos. Exophthalmos grading, mild exophthalmos, you will have one Graffy's, Dahl-Rimte, Stellwachs. Moderate exophthalmos, you will have Geoffroy's. And Mobius is seen in severe exophthalmos. And there is finally malignant exophthalmos. Malignant is last stage. So malignant exophthalmos known as ophthalmopathy. Graves ophthalmopathy. The patient will have epiphora, congestion, redness. Okay, epiphora, congestion, redness. If you're not going to treat, they will even lose the eyesight. So that is malignant exophthalmos. So these are the eye signs. One Graffy's lid lax sign, Dahl-Rimte's lid retraction sign, Stellwachs staring look, and Geoffroy's absent wrinkle sign, and Mobius inability to converge eyeball. So all these eye signs I want you to remember. So please don't forget all these eye signs. And other things which I want you to remember here are Jelinek sign, not much important, just for completion. Jelinek is pigmentation in upper eyelid. Pigmentation in upper eyelid. Pigmentation in upper eyelid. And what is Naves-Ziegel's test? Naves-Ziegel's test. So it is an interesting test. You see, in exophthalmos patient, the upper eyelid is having Muller's muscle spasm. In exophthalmos patient, if you see, there is Muller's muscle spasm present. There is Muller's muscle spasm is present. Whereas there is one more similar condition known as proptosis. Proptosis. What is the difference between exophthalmos and proptos? It is a basic MBBS level question. Exophthalmos is a pathology in the eyeball itself. The eyeball itself having pathology. Whereas proptosis is a pathology behind the eyeball, like a tumor behind the eyeball, like a optic nerve sheath tumor. All those things will cause proptosis. So proptosis is pathology behind the eyeball. So therefore, if you see, we can in childhood you would have played like this by averting the upper eyelid. That averting of upper eyelid we have to do. So averting of upper eyelid test is known as Gifford's test. Gifford to differentiate between exophthalmos and proptosis. So Navziger's test is a test you see from the supraorbital ridge. You make the patient sit down and you see from the supraorbital ridge. Usually the eyes will not be seen. Above the supraorbital ridge, you will never see the eyeball. So supraorbital ridge, beyond the supraorbital ridge, eyeball seen. It is known as Navziger's test. So there is a classification based on Navziger's test, which is not important for you. But remember, rare test. Jelinek sign is pigmentation of upper eyelids. Navziger's is examining the exophthalmos from supraorbital ridge. From supraciliary ridge, you have to examine. Gifford's test is to differentiate between exophthalmos and proptosis. That eversion of it is nothing but eversion of upper eyelid. Eversion test of upper eyelid. It is not possible in exophthalmos. It is possible in proptosis because this is due to Muller's muscle spasm. Muller's muscle is seen in the upper eyelid. That Muller's muscle spasm prevents the eversion, prevents you doing eversion in Gifford's test. In Gifford's test, Muller's muscle spasm in exophthalmos prevents you from everting the upper eyelid. So these are the important tests I want you to remember in this topic. So now please don't forget this point, okay, regarding this point. Now you can see an exophthalmos patient is now admitted with all these eye signs, with the Graves' disease admitted in your patient. So now what are all the methods to diagnose? Diagnosis of exophthalmos is very easy. Clinically you can diagnose. But you can also do other investigations like thyroid profile. T3, T4 will be increased, TSH will be decreased. So very simple test. So thyroid profile will be there. And when you do radioactive iodine uptake will be increased. And you can see autoimmune antibodies will be present. Autoimmune antibodies will be elevated, like anti-thyroglobulin antibodies, anti-thyroperoxidase antibodies, okay, anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies. All these antibodies are elevated in 75% cases, okay. And you will also have LATS, long-acting thyroid stimulator, will be increased. So please remember, this question came in NEET 2020. So long-acting thyroid stimulator is elevated in Graves' disease. Is a NEET PG 2020 question. NEET PG 2020 question, long-acting thyroid stimulator. So this is also known as thyroid stimulating antibodies, TSAB. Thyroid stimulating antibodies or long-acting thyroid stimulator are elevated in around 90% cases. Long-acting thyroid antibodies are elevated in 90% cases. It is nothing but TSH receptor antibody, which is stimulatory antibody. So it is a TSH receptor stimulatory antibody is known as thyroid stimulating antibody or long-acting thyroid stimulator. So long-acting thyroid stimulator is increased in Graves' disease. Usually FNAC will not fetch a good finding because it is full of hemorrhagic aspirate. So FNAC will not be much beneficial. There will be hemorrhagic aspirate. And especially final year students, they will be expecting you to tell this. Hemorrhagic aspirate will be there and there may be bleeding also. So therefore FNAC is not advised for Graves' disease patients. So please remember, final year students, FNAC is not advised for Graves' disease. Graves' disease is easily diagnosed by measuring long-acting thyroid stimulator antibody, by measuring anti-thyroglobulin, thyroid peroxidase in 75% cases, and there is increased radioactive iodine uptake, which I already told you in the first session itself. Now coming to the management of Graves' disease. So the management of Graves' disease is simple. Either we have to give radioactive iodine ablation therapy. Radioactive iodine ablation therapy is one method. Another method is by doing surgery. Only two methods we have: radioactive iodine ablation or surgery. So which is the gold standard treatment? Means radioactive iodine ablation is the gold standard treatment. Surgery is indicated. I will tell you what are the indications. But whatever it may be, before doing surgery or radioactive iodine ablation, there is a very important thing that should be done here. There is a very important thing that is discussed in this blue color box. What is the thing that you should do here before giving radioactive iodine ablation or before doing surgery? What you should do here? We should do preparation of the patient. Preparation of the thyrotoxic patient to euthyroid state. High yield MCQ topic. To euthyroid state is very, very important. We cannot directly go and give radioactive iodine, or you cannot go and directly do surgery. If you don't prepare them to euthyroid state before these procedures, patient may land up in a very drastic complication known as thyroid storm, which I will discuss separately. Thyroid storm is a dangerous complication. So to prevent this, we have to prepare them to a euthyroid state by using 3 drugs. There are 3 categories of drugs used to prepare the patient to euthyroid. Typical final year question. The drugs are anti-thyroid drugs. Anti-thyroid drugs. So anti-thyroid drugs are the drugs which inhibits the steps like, in physiology I discussed, no, it inhibits the steps like trapping of iodine. Trapping, and they inhibit oxidation step also. So they inhibit trapping of iodine and inhibit oxidation of iodine to iodide. And interestingly, there is one more step inhibited by one drug, that is only propyl thiouracil, also inhibits peripheral conversion of T3 to T4 is also inhibited by one drug, that is propyl thiouracil. It will also inhibit this. Now, the commonly used drugs are carbimazole, methimazole, and propyl thiouracil are the commonly used drugs. So methimazole is given in a dose of 10 to 30 milligram in a TDS dose. But the problem is with carbimazole, methimazole, and propyl thiouracil, to become euthyroid will take a long period of around 3 to 6 months. It will take to become euthyroid. To bring the patient to euthyroid, it will take 3 to 6 months. So we have to give these drugs for a long period. So the problems, another MCQ which is expected here is, what is the dangerous side effect of giving a carbimazole? What is the dangerous side effect of giving carbimazole? Is reversible agranulocytosis. It's a pharmacology MCQ. On giving carbimazole, there is a dangerous side effect, reversible agranulocytosis. Therefore, final year students, you should ask history of sore throat. History of sore throat should be asked. When you are having a thyroid patient who is on anti-thyroid drugs, you should ask history of sore throat. It is the first sign in a decreasing WBC count. So reversible agranulocytosis is one of the complications of carbimazole. And in pregnant patients, what is the drug used? Pregnant patients. In pregnancy, we use propyl thiouracil because it will not cross the placental barrier. It not crosses placental barrier. So in pregnancy, propyl thiouracil is advised. Okay. So please don't forget the most dangerous side effect with anti-thyroid drugs. So no, sir, I want to prepare the patient early. I want to treat them in 2 weeks, 2 to 4 weeks. Within 2 to 4 weeks, I want to prepare. That is a quick preparation. Quick preparation. So you have to do quick preparation of thyroid. Quick preparation of thyroid. What do you do? In a quick preparation of thyroid, we have to do beta blockers. We have to give beta blockers. Will be given for quick preparation. And beta blockers are propranolol. We have to give propranolol. Usually used drug is propranolol, and now we are using nadolol. Long-acting 160 milligram OD dose nadolol is used now. Previously we were using 40 milligram TDS of propranolol. So please don't forget, propranolol and nadolol are the 2 drugs we are using. Okay, beta blockers is used for quick preparation of the thyroid gland. Please don't forget this point. Quick preparation of the thyroid gland, we have to use propranolol and nadolol. And why? Because while giving these drugs, it decreases the sympathetic activity. It decreases the sympathetic overactivity of the It decreases the sympathetic overactivity of gland. Okay, decreases the sympathetic overactivity of the gland. Therefore, it becomes yearly preparation is possible with these drugs. And what is the third group of drugs? Third group of drugs is Lugol's iodine. Lugol's iodine is the third group of drug which we use. We use 5% iodine plus 10% potassium iodide is nothing but Lugol's iodine. So this is used as 10 drops TDS. It is used as 10 drops TDS for last 10 days before surgery. 10 drops TDS is given for last 10 days before surgery. Please remember, Lugol's iodine 10 drops TDS is used for last 10 days. It decreases the vascularity of the gland. It decreases vascularity and it makes the gland firm gland. It makes the gland as firm gland. So it makes the gland firmer. It decreases the vascularity of the gland. So these are the advantages of Lugol's iodine. So these are the 3 points you should not forget. In preparation of thyroid 2, euthyroid, what are the things you should not forget is I will use anti-thyroid drugs, I will use beta blockers, and I will use Lugol's iodine. These are the drugs I use for the patients. Okay, so there is one typical question for final MBBS students that is known as block and replacement therapy. Block and replacement therapy is given. So what is this block and replacement therapy in preparation is we give both anti-thyroid drugs also will be given along with thyroxine will be given. Thyroxine as well as anti-thyroxine will be given. It is one type of preparation. So we block the thyroid gland at the same time give some thyroxine, but when you give some thyroxine it will still inhibit the thyroid production from the patient. So this is block and replacement therapy. So this is how you prepare the thyroid gland to euthyroid state. And once the patient becomes euthyroid, the commonly used mode of treatment is radioactive iodine therapy. The commonly used treatment is radioactive iodine therapy. So the drug used is iodine 131 is the mainstay of treatment and the dose is 8 to 12 millicuries is commonly used. We have discussed about radioactive iodine already. The commonly used dose is 8 to 12 millicuries is commonly given to the patient, mix it with the milk and isolate the patient for how many days? When the therapy is going on, isolate them for 8 days. The half-life is 8 days, so you should isolate them for 8 days. Where all the places iodine 131 is contraindicated. So it is contraindicated in pregnancy, children, smoking females. It is contraindicated in smoking females, and for patients who are having Graves' ophthalmopathy. If there is already a Graves' ophthalmopathy, this will get exaggerated. So pregnancy, children, smoking, Graves' ophthalmopathy are the typical contraindications of this. And when you have nodule is present in the thyroid gland, then again it is a contraindication. Okay, so please don't forget pregnancy, lactation, children, smoking, Graves' ophthalmopathy, and nodules are present are typical contraindications for radioactive iodine therapy. And these are nothing but again the indications of surgery. These are nothing but indications of surgery. Okay, now please remember this point. So where all you should not use radioactive iodine therapy. And if I am going to use radioactive iodine therapy, what happens? What happens to the patients? If I am giving radioactive iodine therapy to the patients, after radioactive iodine ablation, in 2 months, what happens? In 2 months, 50% of them become euthyroid. Please don't forget, 50% of them become euthyroid in 2 months. Okay, so more than 50%. In fact, more than 50% euthyroid becomes euthyroid. But the problem is, in 6 months, what happens? In 6 months, if you go and see them again, 50% will be still remaining euthyroid, and the remaining 50% will be either hypo or still hyperthyroid. So this is one line from Benign Love. I want to tell you this line. In 2 months, most of them we can. There is no percentage actually given in Benign Love. Most become euthyroid. But in 6 months, see what happens? 50% only will remain euthyroid, and remaining guys will 50% will become hypo or hyperthyroid. So this is one problem with radioactive iodine ablation therapy. This is one problem with radioactive iodine ablation therapy. So therefore, surgical treatment is opted in many places. Surgical treatment option is nothing but total thyroidectomy. We have to go for total thyroidectomy, no more compromise. We have to remove everything in the neck. Total thyroidectomy is advised for Graves' disease nowadays. And what are the indications of surgery? What are the indications of surgery? Already the contraindications. When radioactive iodine is contraindicated, you can put pregnancy, lactation, children, everything. In pregnancy, you can do the surgery in second trimester. Okay, and suspicious of cancer. If you're suspicious of any cancer, or when the goiter is very big goiter size is very big, more than 80 grams, it is more than 80 grams, and there are compressive symptoms, pressure effects are there. When there are compressive symptoms, and please don't forget what are all the contraindications: pregnancy, lactation, smoker, Graves, ophthalmopathy, everything will come here. Wherever radiotherapy is contraindicated. So suspicious of cancer, okay, compressive symptoms. Then patient not responding to radioactive iodine, And finally, for patients who want rapid control, I want to become normal immediately. Rapid control is needed is another indication. So these are the places where we do total thyroidectomy. While we are going into surgery for toxicosis like toxic goiter, be careful. Be careful with what? The problem which can happen: thyroid storm. Thyroid storm. The most common cause of this complication is inadequately prepared thyrotoxicosis patient taken for surgery is the most common cause. Most common cause of thyroid storm is inadequate preparation. Please don't forget, inadequate preparation is the most common cause. That is the most common cause of thyroid storm. And in thyroid storm, you have to remember these points. So thyroid storm is a condition of hyperthyroidism associated with the following features. What are the features? CNS problem, then CVS problem. There can be CNS or CVS issues. So the CNS can go for agitation or depression. CNS agitation or depression. CNS agitation or depression. And for CVS, the CVS dysfunction is very dangerous. CVS dysfunction. So patient will land up in congestive cardiac failure. The causes are inadequate preparation, any illness, any stress, like drugs like amiodarone. All these things are various causes of thyroid storm. So, but please remember, the thyroid storm is very dangerous because 10% mortality is seen in these cases. 10% die. When you see an episode of thyroid storm, in spite of all your extensive management, 10% will die. And a thyroid storm is characterized by severe tachycardia, hyperpyrexia. The temperature will increase like anything. Dehydration. The patient go for dehydration due to sympathetic overactivity. There will be congestive cardiac failure and hyperexcitability. And patients will land up in atrial fibrillation also. So these are the various dangerous issues with these guys. So various dangerous issues with thyroid storm. So please, finally, this is a separate chart note for you. Thyroid storm. So please be thorough with thyroid storm. So the treatment of thyroid storm are basic life support, BLS. Basic life support should be treated like giving oxygen, tepid sponging for fever, tepid sponging, give them IV fluids, and give them glucose. All these things are basic things you should do. All these are basic things. And specifically, the problem here is it is due to rough handling of the thyroid gland. Excess thyroxine hormone is released into the circulation. Therefore, we should start anti-thyroid drugs. So anti-thyroid drugs will be given in IV. Please remember, IV will be given. IV propranolol. You have to give IV propranolol. We have to give Lugol's iodine. Whatever we discussed, please remember, whatever we discussed, propyl thiouracil, carbimazole, some of these drugs will be effective now. We have to give them in excessive dose. We have to give them excessive dose. And we can even give potassium iodide in IV. So this question is an expected PG question. What are all the drugs used in thyroid storm? So the drugs used are IV propranolol, Lugol's iodine, propyl thiouracil, carbimazole, potassium iodide in IV. And what you must remember here is, apart from all these things, we also use steroids. So what are the special drugs used? Special drugs used in a thyroid storm to save the patient. Special drugs are steroids are used because adrenal gets exhausted. So give them steroids. Give them diazepam. They are hyperexcitable. Please give them, sedate them with diazepam. Give them diuretics because they are having CCF. Give them diuretics and also give them digoxin. So this is a high yield MCQ topic. So what please see the topic, please see the points. What are all the drugs used in atrial fibrillation? So basic life support with oxygen, tepid sponging, IV fluids, glucose will be going on one side. Antithyroid drugs will be going in an IV method, and special drugs like steroids, diazepam to rest the patient, diuretics for congestive cardiac failure, digoxin for atrial fibrillation. All these things will be given for thyroid storm cases. So please remember, thyroid storm is a very important topic for your exams. It's a very important topic for your exams. You should not forget thyroid storm. So this is about the Graves' disease. So what are the other causes of toxicosis? I have discussed Graves' disease. So far I have discussed Graves' disease. So the catch points in Graves' disease are: it is common in young females. It is common in young females. It is autoimmune. Long-acting thyroid stimulator is present. It is treated by radioactive iodine therapy is the treatment of choice for Graves' disease. All these are basic things about Graves. Now coming to your exam case. Will you get Graves' disease as your exam case? Finally, students, will you get exam case? Never they keep Graves' disease, because when a Graves' disease patient is kept for you in the exam, all of you will go and examine the thyroid gland and you will admit him as a thyroid storm patient. Thyroid storm will happen because of continuous compression of the gland. So you will not be kept Graves' disease in your exam. So toxicosis patient which is kept for your exam is either a solitary nodular goiter going for toxicosis or a multinodular goiter going for toxicosis. So solitary nodular goiter going for toxicosis or multinodular goiter going for toxicosis is what kept for your exams. The solitary nodular goiter going for toxicosis is known as plumber's disease. These cases will have only serious manifestation. They have serious manifestation. Why? Because this is common in old age. They are common in old age. Old age, the patient's heart is already compromised, so they have more of serious manifestation. CNS manifestation is very rare. If at all, only eye signs, few eye signs like lid lag sign may be present. Lid lag and lid retraction only may be present. Not all signs are seen. Only lid lag and lid retraction will be present. So they may have only lid lag and lid retraction sign. Otherwise, they don't have other signs. So the treatment of choice for these patients is same like Graves. We have to prepare them to euthyroid status. Preparation of them to euthyroid status. After they become euthyroid, then only we should plan for treatment. And here the treatment of choice is surgery, because there is nodules. Radioactive iodine is not usually used. We mostly use surgery. So the surgery done for these cases will be subtotal thyroidectomy will be done. Subtotal or total thyroidectomy both can be done for these patients. Secondary toxicosis patients. These are all known as secondary toxicosis because the goiter goes for secondary toxicosis after a long period. The swelling is present for more than 3 months, 6 months, 1 year. Now it is going for toxicosis. This is known as secondary toxicosis. Okay, please don't forget this point. Okay, so this is very important basic point about toxicosis or toxic thyroid goiters. Okay, about the swellings, we have discussed about the toxic swellings and normal swellings. Now let me go to the next swelling in thyroid gland known as thyroiditis. Thyroiditis. So what are the thyroiditis means? Thyroiditis means inflammation of thyroid gland. So thyroiditis can be divided into the following headings. I'm going to make it in a single flow chart. What are the thyroiditis? Hashimoto's thyroiditis, Hashimoto's thyroiditis, Riedel's thyroiditis, D. Corvine's thyroiditis, D. Corvine's thyroiditis. Then comes acute thyroiditis. So now I'm going to discuss the MCQ points in all these thyroiditis. Thyroiditis is an acute inflammation of the thyroid gland. Acute inflammation of the thyroid gland, acute or chronic inflammation of thyroid gland. Hashimoto's is the most common type of thyroiditis. Most common type of thyroiditis is Hashimoto's thyroiditis. It is also known as chronic lymphocytic thyroiditis, chronic lymphocytic thyroiditis, or autoimmune thyroiditis. It is known as chronic lymphocytic or autoimmune thyroiditis. It is following an autoimmune process. Hashimoto's thyroiditis is an autoimmune process. In this, the following antibodies are increased. Most common antibody increased is thyroid peroxidase, okay, followed by thyroglobulin and TSH receptor. So these are all inhibitory antibodies. Please remember, in toxicosis we had stimulatory antibodies. Here all these are inhibitory antibodies seen. So the most common antibody here is thyroid peroxidase antibody. Basic repeat question, 100 times asked question for you. Thyroid peroxidase antibody. FNAC of Hashimoto's thyroiditis shows what cells? When you do FNAC, what cells will be seen? Recent NEET PG 2020 question, that is Hurtl cells. Will show you the image. Hurtl cells are seen and plenty of lymphocytes are seen. Plenty of lymphocytes seen and Hurtl cells are seen. What is the other name of Hurtl cells? Also known as Hurtl cells, also known as Ashkenazi cells. Hurtl cells also known as Ashkenazi cells. So please don't forget, Hashimoto's thyroiditis is characterized by chronic, also known as chronic lymphocytic or autoimmune. The most common antibody is thyroid peroxidase antibody, followed by thyroglobulin TSH receptor. FNAC shows presence of Hurtl cells. FNAC shows Hurtl cells are lymphocytes. So what is the presentation of this, guys? What are the presentation? What is the clinical presentation? They come to you with the painful thyroid swelling, pain present. And initially they will have thyrotoxicosis. There will be increased release of hormones. It is not due to increased production, it is due to increased release of hormone. Initially there will be thyrotoxicosis, but soon the thyroid gland will be burnt out, and finally the patients will mostly have hypothyroidism will be the last feature. So most of the thyroiditis patients will initially have thyrotoxicosis features followed by hypothyroidism. So this is the presentation these patients will come to you. Okay, hypothyroidism will be present initially, then it become initially thyrotoxicosis, then becomes hypothyroidism. So there will be initially pain, and similarly later that will be painless. Initially there will be pain, but later it will be painless. In fact, when you see the patient, most of the time as a surgical consultant, you will see painless enlarged thyroid with hypothyroidism. Classical presentation. The most common presentation of Hashimoto's is painless enlargement of thyroid gland with hypothyroidism. So what are all the complications? What are all the complications of Hashimoto's? So why should you worry about Hashimoto's? There are so much of circulatory antibodies against the important substances like thyroid peroxidase, all those things. So the complications, very important complication is hypothyroidism. Therefore, they'll end up in hypothyroidism finally. They will have compressive symptoms. They will have compressive symptoms. Very important point you should remember for your exams is they can produce pre-malignant. It is pre-malignant. Hashimoto's is pre-malignant. It can produce what tumors? It can produce lymphoma or what are the tumor? Lymphoma or that is an MCQ. Papillary cancer. It can produce lymphoma or papillary cancer. Please don't forget. The two tumors produced by this are lymphoma and papillary cancer, or the tumors produced by Hashimoto's thyroiditis. So therefore, when a patient with Hashimoto's comes to you, what is the treatment? So there is nothing to scare in Hashimoto's. Just give them tablet thyroxine. If they have a pain, give painkiller. And surgery is not at all advised. It's not advised. Because it is very difficult to do operate on Hashimoto's. There will be severe dense adhesions and the chances of injury to the nerves will be more. So surgery is not advised except only one reason, that is for compression effects. If there is a compression in the esophagus, then only you should do surgery. Otherwise, surgery is not advised. Surgery is not advised. So please remember, surgery is not advised for these cases. Hashimoto's thyroiditis. These are the important points I want to remember. Now coming to Riedel's thyroiditis. So Riedel's thyroiditis is a thyroiditis which is associated with, it is an invasive fibrosing condition, fibrous thyroiditis, associated with Dupuytren's contracture, retroperitoneal fibrosis. All these are fibrosing conditions like Dupuytren's contracture, retroperitoneal fibrosis. All these are seen in Riedel's thyroiditis. And these patients, when they present itself, they are always hypothyroid. There is no hyperthyroid feature seen. Always hypothyroid. Please remember, it is a Ames question. Which thyroiditis is always hypothyroid? It is Riedel's. There is no episode of hyperthyroidism. It is always hypothyroid, and they will produce compression. Compressive symptoms will be present. It is all thyroiditis are common among females. All are more common among females in the age group of around 30 to 40 years. All thyroiditis are common among females in the age of 30 to 40 years. And I would like to tell you one interesting thing in Riedel's. FNAC cannot be done. Please remember, when you put the needle inside, it will be woody hard like a malignancy. Woody hard swelling like a malignancy. Mimics like cancer. It mimics cancer and it is woody hard. You cannot even put your needle inside. Therefore, if at all you want, you have to go for true cut biopsy. There are only two places you do true cut biopsy in thyroid. One is Riedel's thyroiditis, another is, where is the second one? One is Riedel's, another is anaplastic cancer. If at all you want to take tissue, you should take true cuts biopsy only. Only two places we will advise true cut biopsy. In this condition, we will advise true cut biopsy. Okay. So the treatment of this condition, Riedel's. So treatment is again tablet thyroxine because they are hypothyroid, no doubt. Tablet thyroxine will be given. Steroids will be given. Steroids are found to be little beneficial. Interesting point is anti-estrogen is found to have some benefit like tamoxifen. Anti-estrogen like tamoxifen is found to be beneficial. And recent drug like mycophenolate mofetil is also beneficial. So what are the drugs used in Riedel's thyroiditis are thyroxine, steroids, tamoxifen, mycophenolate, mofetil are used for Riedel's thyroiditis. So please remember the interesting point in Riedel's is it is always hypothyroid. It is always hypothyroid. Riedel's is always hypothyroid. So de Quervain's thyroiditis is also known as what? It is also known as post-viral thyroiditis, inflammatory response, or subacute thyroiditis. It is also known as post-viral or subacute thyroiditis. Please don't forget, it is post-viral or subacute thyroiditis. It happens after few weeks. After few weeks of viral infection, this happens. After few weeks of viral infection, we get de Quervain's thyroiditis, and it is associated with HLA-B35. It is associated with HLA-B35. It is associated with HLA-B35 association is seen. So what is the MCQ? 100 times asked MCQ in de Quervain's. 100 times asked MCQ is about the clinical feature. It is predominantly hyperthyroid for long period. It is predominantly hyperthyroid for long period. But it is also going to become hypothyroid finally. But long period it will be hyperthyroid. Now comes the typical clinical question. So now a patient is coming to you, 25 years young female is coming to you with the toxic features. There is tremors, there is eye signs, there is palpitation, everything is seen. And you are having a doubt whether it is Graves' disease or de Quervain's. How to differentiate? How to differentiate? Differential diagnosis is Graves' disease. How to differentiate from Graves' disease? Interesting point is Graves' disease will have increased radioactive iodine uptake. Please don't forget this. Whereas de Quervain's will have, when you do radioactive iodine uptake study, it will have decreased radioactive iodine uptake and there will be increased ESR in de Quervain's thyroiditis. So what is the important differential diagnosis of de Quervain's is it will have decreased radioactive iodine uptake and increased ESR when compared with Graves' disease. Graves' disease will have increased radioactive iodine uptake. The point is because in Graves' disease there is excessive production, but in de Quervain's there is no excessive production, there is only excessive release. Therefore, de Quervain's will have decreased radioactive iodine uptake in spite of hyperthyroidism. In spite of hyperthyroidism. This is what I told you in the beginning. In spite of hyperthyroidism, we have this problem. Please don't forget this. In spite of hyperthyroidism, there is decreased radioactive iodine uptake. Please don't forget this point in de Quervain's. And the treatment is very simple. You have to give analgesics. Painful, so give them analgesics, nothing else. And steroids. You just give analgesics and steroids. That's enough for de Quervain's thyroiditis. And finally, coming to the acute thyroiditis. Acute thyroiditis is mostly caused by bacterial infection. So please remember, bacterial infection causes acute thyroiditis and it is most commonly follows as streptococcal. Streptococcal. Immediately, it is seen immediately and it is more common in children. It is seen immediately and more common in children and there is no HLA association. One interesting line from William Law I want to tell you here. If there is a patient coming to you with acute thyroiditis and you should rule out one important pathology known as persistent pyriform sinus fistula. Persistent pyriform sinus fistula you should rule out. So persistent pyriform sinus fistula is one of the important causes of recurrent acute thyroiditis. It is one of the important causes of recurrent acute thyroiditis. Recurrent acute bacterial thyroiditis. So this point I want you to remember. Please don't forget this point. Expected MCQ, this point. So patients, young babies, small children coming to you with a recurrent thyroiditis following upper respiratory infection. Upper respiratory infection which is causing sore throat will spread directly if there is a persistent pyriform sinus fistula into the thyroid gland and cause thyroiditis. Okay, please don't forget they will present you with a severe neck pain and odynophagia and there will be increased ESR, increased WBC count. Everything will be increased. So please remember this is one of the important pathology you should not forget. It can cause severe complications like laryngitis. Complications of acute thyroiditis are laryngitis, perichondritis, sepsis. They are more dangerous. See, tracheal rupture. They can cause tracheal rupture, esophageal rupture. IJV thrombus. So to be frank, I have not seen a case of acute thyroiditis so far. Just from what is there from Sabiston, I'm telling. What are the points in Sabiston? Laryngitis can happen, perichondritis, sepsis, tracheal rupture, esophageal rupture, IJV thrombus, everything can happen. Okay, so if it is recurring again and again, the treatment is we have to give high antibiotics, and we have to remove the fistula, remove the pyriform sinus fistula. So please don't forget these points. These points I want to remember in thyroiditis. Thyroiditis is not essential for final year students. It's not so important topic for final year students, but for PG aspirants, high yield topic. So I will tell you what are the questions asked from thyroiditis so far from this whatever written here. Huckel cells on FNAC is seen in Hashimoto's. NEET 2020 question. Most common antibodies seen in Hashimoto's. Thyroid peroxidase. NEET 2019 question. And what is the tumor seen in Hashimoto's? Papillary cancer. Okay, papillary cancer. Riedl's thyroiditis is always having hypothyroidism. Riedl's thyroiditis will always have hypothyroidism. And FNAC not possible in Riedl's. Tamoxifen is used in Riedl's. Important differential diagnosis for D. Corvine's disease is Graves. What is the cause of acute bacterial thyroiditis recurrent? Persistent pyriform sinus fistula. So all these are essential core MCQ topic from thyroiditis. So though it is not essential or so important for final years, I want PG aspirants and super specialty aspirants to concentrate more on this topic. Okay. So now we are going to discuss two important topics. One is retrosternal goiter. Retrosternal goiter. Okay, retrosternal goiter. Past few years I am seeing all the exams. I don't know why the examiners are more craving on retrosternal goiter. So regularly they are asking questions from retrosternal goiter. So let us see some points from retrosternal goiter. You see, a patient is having a thyroid swelling here. I told you already, because of pretracheal fascia attached to the hyoid bone, we cannot see the thyroid gland extending upwards. There is no place for it to be extending upwards because the pretracheal fascia attaches to the hyoid bone, and also the sternocleidomastoid muscle attachments prevent it going upwards. Therefore, the swelling is more enlarging downwards. As it enlarges downwards, it will enter into which mediastinum? It will enter into superior mediastinum. Superior mediastinum it enters. So this concept of entry of the gland into the superior mediastinum is known as retrosternal goiter. So there are two types. In this, the types of retrosternal goiter are primary mediastinal goiter. Primary mediastinal goiter and secondary mediastinal goiter. In case of primary mediastinal goiter, please remember, in case of primary mediastinal goiter, it is arising from an ectopic thyroid gland present inside the chest. It is arising from an ectopic thyroid gland present inside your chest. So therefore, it is very rare, less than 1%. And since it is arising from the chest, it receives blood supply from the thoracic vessels. So blood supply is from thoracic vessels. Whereas secondary mediastinal goiter is an extension from the neck. It is a typical retrosternal extension. Retrosternal extension. It is seen in around 90% of the patients. So 99% of the cases, the goiter we get is retrosternal extension of neck goiter. So therefore, you can see it is receiving blood supplies from only superior thyroid artery and inferior thyroid artery. So therefore, secondary mediastinal goiters are nothing to worry. You can approach through the neck incision itself. By neck incision itself, you can put your finger inside and hook it out. You can hook it out. That maneuver is known as toboggan maneuver. That maneuver of putting your finger and removing it, that is the only name. That is the surgeons usually keep some name for everything. So when you keep a finger inside and remove it, it will come out. That is known as toboggan maneuver. So by neck incision and toboggan maneuver, we can remove most of the mediastinal goiters. Only for primary mediastinal goiters, we need sternotomy. For primary mediastinal goiters, we need sternotomy and we have to go inside and remove it. So please remember, these type of mediastinal goiters can compress the SVC and can cause superior vena cava compression syndrome. To find it out, we do a test known as Pemberton sign. Pemberton sign I explained you. Ask the patient to extend the arms and touch both ears. You have facial puffiness and congestion. Pemberton sign is positive. And NEET 2020, the question was very clear. Investigation of choice. And what is the investigation that is compulsory before surgery? Before any surgery, what is the investigation to be done? Answer is CECT thorax. Before surgery, we must always do CT thorax. It is compulsory. So we have to do CT thorax and the neck, and we have to look out for where are the vessels extending. Everything we have to do neck and thorax before doing surgery. Before doing surgery, we must do this. And surgery is not always needed. For elderly patients, asymptomatic guys, asymptomatic patients, we can wait and watch. Asymptomatic elderly patients, wait and watch can be done. But for young people, we have to do surgery by neck incision. So can you tell me indications of thoracotomy in a retrosternal goiter? Indications of sternotomy or thoracotomy for a retrosternal goiter. This question is an expected question, directly taken from Bailey and Lowe. Please remember, directly taken from Bailey and Lowe. Previous neck surgeries. Previous neck surgery being done, that is full of fibrosis. Recurrent retrosternal goiter, recurrent cases. The extension is not into superior mediastinum, but it extends into posterior mediastinal extension. That is a posterior mediastinal extension. So please remember what are all the indications of surgery means. Previous neck surgery being done, recurrent retrosternal goiter, posterior mediastinal extension, and presence of primary mediastinal goiter. Means what? Blood supply is from the mediastinal vessels. So presence of primary mediastinal goiter. These are important things you should not forget. Or there is dense adhesion in the mediastinum, adhesions present in the mediastinum. So these are the patients for whom we will do sternotomy. Otherwise, we will remove 99% of the cases only by neck incision and toboggan maneuver. Please don't forget this. Retrosternal goiter, one of the high-yield topic for exams. Retrosternal goiter you can get for final years. Next topic is thyroglossal cyst. Thyroglossal cyst. So this is an embryology question. Actually, this is an embryology question. You all very well know this. So thyroglossal cyst is arising from the thyroid gland arises from a tract which is extending down from the foramen cecum. The thyroglossal tract goes down, divides into bud and forms thyroid gland. If there is a persistence of this tract somewhere and results in the formation of your cyst, it is known as thyroglossal cyst. It is a persistence of this tract somewhere results in cyst known as thyroglossal cyst. So the important clinical feature is, though it is a congenital cyst, the common age group of presentation is 15 to 25 years and is common in females. And classical point is, this is not only moving with deglutition, it also moves with protrusion of tongue. This is the only swelling moving with protrusion of tongue. On protrusion of tongue, thyroglossal cyst moves up. And the most common position is always below hyoid bone. It can be seen all along the course, but most common position is subhyoid position. Subhyoid position is the most common position of thyroglossal cyst. The complications of this cyst are very interesting. So the most common complication is infection of the cyst. Most common complication is infection. And following an infection, it can rupture and result in thyroglossal fistula. So please remember, interesting point is this: following infection, the thyroglossal cyst becomes ruptured and becomes a thyroglossal fistula. It is known as congenital acquired. It is only acquired. There is no congenital thyroglossal fistula. Interesting point. There is no congenital thyroglossal fistula, but thyroglossal cyst is congenital. There is no congenital fistula. Always it is an acquired fistula following a rupture of the cyst. Following a rupture of the cyst or following an incision drainage done by you, this fistula happens. So please don't forget, the most common complication is infection. The most important other things are thyroglossal fistula and malignancy. So malignancy is another important complication of thyroglossal cyst. This is an expected MCQ. What is it? What is the malignancy scene? It is papillary cancer. Papillary cancer is a malignancy scene. So please don't forget, the malignancy scene is papillary cancer scene in thyroglossal cyst. Okay, investigation of choice for thyroglossal cyst is ultrasound of the neck. So ultrasound of the neck is enough as an investigation of choice to diagnose thyroglossal cyst. So interesting point, you should not forget, ultrasound neck is an investigation of choice to diagnose thyroglossal cyst. I want to tell one interesting fact here. Before operating for a pediatric cases, before operating, what I should do? One important investigation I should do, not needed for adult. What is it? It is radioactive iodine uptake study. Because I want to know whether the normal gland is present or not. I want to know whether the normal functioning gland is present or not. Therefore, I will do radioactive iodine uptake study. I will do radioactive iodine uptake study always in pediatric cases. Because if there is no active functioning thyroid gland like this, and if this is the only functioning gland, what I will do in pediatric cases? I will delay the surgery until the baby grows. Otherwise, what will happen? If the only functioning thyroid tissue, which is thyroglossal cyst, is removed, the baby will land up in cretinism. So I will wait in those cases. Therefore, in pediatric cases alone, this investigation advised. Radioactive iodine study advised in pediatric cases. So otherwise, the treatment is cyst trunk operation. All of you know the answer: cyst trunk operation. The interesting thing in cyst trunk operation is we have to remove the entire tract along with what? This is hyoid bone. See, this is a tract. So I will remove the entire tract like this, along with I will cut the central part of hyoid bone also, not the full hyoid bone. In a cyst trunk operation, I will cut the central part of hyoid bone. Central part of hyoid bone removed. Please remember, central part of hyoid bone removed in cyst trunk operation. Please don't forget. Cyst trunk operation, central part of hyoid bone is removed out. Okay, I want you to remember this point. So there is one more place we do cyst trunk operation. Where we do cyst trunk operation? Cyst trunk operation is done in thyroglossal fistula or thyroglossal cyst. Another place where we do is in case of lymphedema of the leg. Where will you have the name cyst trunk incision? Cyst trunk incision is done for parotid operations. Parotid operations. Parotid surgery also we do cyst trunk incision. Cyst trunk operation is also there in lymphedema. Is also there for lymphedema. So this is about thyroglossal cyst. This is about thyroglossal cyst. And the last topic in benign swelling I want you to know is about the thyroid cyst. Thyroid cyst. The patient comes to you with a solitary swelling here in the neck. You are doing FNAC. FNAC is showing you clear fluid aspirated. It is coming under Bethesda what classification? Bethesda Ty 1C. So it is a clear cyst. It is a clear cyst. We are going to take a clear cyst. So when all you should do surgery? Indications of surgery. Indications of hemithyroidectomy. In a cyst. The answer is very important for final years as well as for PG aspirants. Number one, incomplete disappearance. After aspirating, it is incompletely disappeared. Still there are some components present. Incompletely disappeared. If it is completely disappeared, nothing to do. Incompletely disappeared. Hemorrhagic aspirate. If it is looking hemorrhagic. In a thyroid cyst, when all we should do hemithyroidectomy. Incompletely disappeared cyst. Hemorrhagic cyst. Hemorrhagic cyst. Solid component is present. There is a solid component present, and the cyst is recurring for more than 3 times aspirated. More than 3 times we have aspirated, it is recurring. 3 times aspirated cyst going for recurrence. So these are the places where we must go for a surgery, hemithyroidectomy. And if the cyst is very big, more than 4 cm also, we can directly go for hemithyroidectomy. Or if the cyst report comes as presence of malignant cells, we have to go for surgery. So when all you should go for hemithyroidectomy in a thyroid cyst. So incompletely disappeared cyst, hemorrhagic cyst, solid component, 3 times aspirated going for recurrence, or more than 4 cm cyst or malignant cells are present, are the places where you have to go for hemithyroidectomy. So these are the benign topics I want you to remember. Number 1, Graves' disease. Number 2, thyroiditis. Number 3, retrosternal goiter. Number 4, thyroglossal cyst. And number 5, thyroid cyst. So now let us show the PowerPoints to you. Let us see the PowerPoints now. Because PowerPoints, I'm uploading all the PowerPoints and the images will be uploaded separately in a surgery 6 app, so don't worry. So what is the classification of thyroid swelling we discussed? So this is a huge goiter which is going for a retrosternal extension, and that is superior vena cava compression. You can see there is dilated veins. So this is a long-standing multinodular goiter going for compression. So this girl is having a retrosternal extension, and I am doing a Pemberton sign for this girl. So this girl is undergoing Pemberton sign. So what is the method of examining thyroid gland? Please see, this is how you would examine. You should always examine thyroid gland from behind, always from behind. And this is what test? What is the name of this test? Image-based question. Piscilos test. Piscilos test. So I have shown you 2 methods of examining thyroid swelling from anterior. So this is known as Lahey's test. And this is known as Kreil's test. Kreil's test, Lahey's test are the 2 tests shown here. Lahey's test, pushing the gland and palpating with 4 fingers. In Kreil's test, you use only thumb and examine. Kreil's test. So please don't forget about the retrosternal goiter points I told you. So the goiters can be otherwise said as substernal, part of nodule palpated in the lower neck. Okay, it is coming from inside to outside, plunging goiter on increased thoracic pressure. On coughing, you can see the gland will come out and go back inside, plunging and intrathoracic goiter. So this is one classification in one book. And what is the classification there in Swartz is primary and secondary mediastinal goiter is a classification from Swartz. I want you to remember the Swartz classification. So what are the complications of retrosternal extension? Please remember dysphagia, tracheal compression and compression of vessels are the complications of retrosternal extension. Always CT chest should be advised. And you can see one of the videos showing you here toboggan maneuver. You are putting a finger inside and mobilizing and taking it out. This is toboggan maneuver of operation of retrosternal goiter. See, I am using my finger to remove it out. Remove the retrosternal goiter. So please remember, it can be removed by neck incision itself. So it is indications of sternotomy or posterior mediastinal extension, malignant suspicion, or in case of revisional cases and blood supply from intrathoracic vessels and large immobile fixed gland are the things you should not forget. Okay, these are the things I want you to remember in toboggan maneuver. Hyperthyroidism, we have discussed all the things. So most common causes of Graves' disease. Thyrotoxicosis factitia is due to excess consumption of thyroxine. George basilosis is due to excess consumption of iodine. And hamburger is due to consumption of thyroid gland itself. Gland itself eating is known as hamburger. Plumber is secondary toxicosis in a nodular goiter is known as plumbers. So please don't forget these things. And clinical features we have discussed. See the pretrivial mixed edema, mucopolysaccharide deposition, glycosaminoglycans. Glycosaminoglycans get deposited in the pretrivial area, giving this appearance. And this is acrobatic subperiosteal resorption in Graves' disease. You can see the staring look of Stillwax. This is Stillwax sign. And visible upper sclera is known as what sign? Visible upper sclera. Lid retraction is known as Dalrymple sign. Okay, visible upper sclera is Dalrymple sign. So please don't forget all the signs I told you. Okay, so female patients experience amenorrhea, miscarriage, and infertility in Graves' disease. They experience miscarriage, infertility. So serious features I told you. So please don't forget Lerman's scratch sound. It's a systolic scratch sound heard in the second intercostal space during expiration. So this is the classification I told you. So mild is Stillwax, 1 graphy, Dalrymple. Moderate is Joffroy. Severe is Mobius. Okay. So medical treatment we have discussed. So block and replacement therapy is a typical final year viva question. When patient becomes euthyroid after 8 to 12 weeks, usually they become euthyroid. The dose can be reduced to 5 mg from 30 mg, and we give a block and replacement regimen. In this case, what we do, the high dose of carbimazole is continued to inhibit T3 and T4 production, and the maintenance dose of 0.1 is given after the patient becomes euthyroid. A thyrotoxic patient before we take for surgery. In that meanwhile gap, we combine the drugs. So for example, simple, you just tell I will combine antithyroid drugs with thyroxine. I will combine antithyroid drugs with thyroxine for this patient. That is known as block and replacement therapy. And very important point I missed to forget in the discussion is when will you give the last dose of carbimazole? Last dose of carbimazole. Tomorrow morning I am having surgery. I should give today night. That's all. Carbimazole is given today night. And propranolol. When will I stop the last drug? I will never stop. Please remember, I will continue the drug even for 7 days post-operatively. I should continue the drugs. So even after during surgery and intra-op and post-op, propranolol will be continued. Please don't forget this points from Bailey and Love. So treatment of choices. First treatment of choice is radioactive iodine. So contraindications of radioactive iodine, pregnancy, lactation, young children, nodules, ophthalmopathy. Please don't forget. Don't forget about thyroid storm. Most common causes inadequately prepared patient. Repeat MCQ. So they will have all the drugs will be given: steroids, diazepam, diuretics, digoxin. Okay, please don't forget we have to give these drugs. Okay, steroids, diazepam, diuretics, and digoxin will be given special drugs. So thyroglossal cyst, I told you it is common in 15 to 30 years. It is moves on protrusion of tongue, and this is a patient with a thyroglossal cyst. You can see a video showing you a thyroglossal cyst in one of my patients. You can see as he is protruding the tongue, how nicely the swelling is moving. The swelling is moving, how nicely it is moving on protrusion of the tongue. So typical thyroglossal cyst. It's a video question you can get in exam. Okay, so these are the various complications, and cyst trunk operation I told you we have to remove the entire duct and the cyst with the central part of hyoid bone. So thyroiditis I told you the most common is Hashimoto's, abundant cytoplasm with varying size of nuclei. Abundant cytoplasm with varying nuclei is Urkel cells, pathology MCQ, FNAC. So the most common antibody is thyroid peroxidase. So renal, subacute, all these things we have discussed, and these are the benign topics in thyroid gland. I want you to remember these are the benign topics in thyroid gland. You should not forget. Okay, so we stop here at benign topics and we'll start the malignant topics next.